The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome. My name is Dr. George Kraft, and I am the host of this 9-part series on MS from A to Z. This is program number 4, and it will be presented by Dr. Charles Bombardier, who is part of the MS Research and Training Center at the University of Washington. We want to bring you topics during this series that are important for persons with MS and for their loved ones and for other people interested in MS. And the topic today is on depression. It is not often talked about, but it is an important part of the disease. Dr. Bombardier is an expert on depression and MS, and will also talk about how exercise can be used to reduce the severity of depression. Dr. Charles Bombardier, thank you very much, Chuck, for coming and doing this.
Thank you, Dr. Kraft. I'm pleased to be able to talk with you today about depression and multiple sclerosis. First of all, I want to acknowledge the many people who have contributed to our work here. First of all, to thank our funding agency, the National Institute of Disability and Rehabilitation Research. We have a grant there on which George Kraft is the PI. I also want to thank our co-investigators, Dr. Don Eady, Dr. Mark Sullivan, Dr. Laura Gibbons, and as well as Dr. George Kraft, who have really facilitated our research over the years on this topic. And finally, I also want to thank our staff members who helped with our last grant cycle: Roini Wadhwani, Chiara La Rotunda, Celeste Hunter, Carrie Madrone, and Kendra White. And finally, I want to thank the people with multiple sclerosis that have helped us. We've learned so much about what they've experienced through their participation. I want to start by just giving a brief overview about multiple sclerosis. Just to remind ourselves that this is a disease of the central nervous system that causes inflammation and demyelination and axonal loss. And it results in kind of an unpredictable course. The course can be progressive or it can be relapsing. It affects about 400,000 people in the United States. It affects more women than men. And MS causes a variety of different symptoms, including fatigue and weakness, sensory and cognitive impairments, and also, in this case, depression. So what I'd like to talk about today is, first of all, starting with what is major depression. We'll talk about the prevalence of major depression, risk factors, the impact major depression has on people's lives, identification and treatment, and then finally summarization. First of all, what is major depression? Well, major depression is a constellation of both physical and psychological symptoms. The physical symptoms include things like insomnia or hypersomnia, sleeping too much or sleeping too little, a lack of energy, significant weight loss or weight gain, moving slowly or sometimes feeling very agitated, and poor concentration. The psychological symptoms include things like depressed mood or loss of interest or pleasure in their usual activities. Sometimes people feel worthless or guilty, and then in some cases people think thoughts of death or of suicide. Now, major depression is common in many neurological conditions, including traumatic brain injury, spinal cord injury, stroke, epilepsy, and so forth. And so multiple sclerosis is just one of the conditions among many where depression may play a role. In terms of the prevalence of major depression, it appears to be higher than in the general population. As you can see on the slide here, the general population in the course of 1 year, about 7.4% are expected to experience a period of major depression. But in the case of people with MS, more than twice as many experience an episode of major depression, about 15.7%. In terms of lifetime prevalence of major depression, about 16.2% of the people in the general population become depressed sometime during their life, whereas in people with MS, 22.8% have an episode of major depression. The next question is really, is depression real? We don't have a good blood test for major depression. We don't have physical signs of major depression. We have mostly what people report to us. So, I argue really that depression is just as real a medical condition as diabetes. Both involve, chemical changes. Both involve some structural changes. Both are influenced by genetic factors, and both are really influenced by behavioral factors, health behaviors as well. Both are really biopsychosocial conditions, and certainly depression is a biopsychosocial condition. On this next slide, I try to lay out a number of the different biopsychosocial risk factors involved in major depression. So you can see there's neurobiological factors, there are activity-related factors, so a lack of pleasant activities. There's risk factors involving psychosocial adversity. So there's a picture of a man here who's just received a pink slip from work. He's been laid off his job. And so we know that things like unemployment and impoverishment can contribute to major depression. Also, it's interesting to note that a sedentary lifestyle can contribute to major depression. And then finally, how we think, especially cognitive distortions, can contribute to major depression. So all these, no one being really a cause of major depression, but all of them being risk factors for major depression, kind of gives us a sense of what we can do to help treat this disorder, and we'll get to that later. The next thing I want to talk about really is just the neuropathology of depression. There's many studies on the neuropathology of depression that touch on various areas. So there's what's called the monoamine hypothesis, in which we think that certain neurotransmitters, namely serotonin, norepinephrine, and dopamine, that these systems are dysfunctional in people with major depression, and that somehow the neurotransmitter systems contribute to this disorder. There also appear to be neuroendocrine abnormalities, especially in the hypothalamic pituitary adrenal axis, that seem to be dysfunctional in people with depression. In depression, surprisingly too, there seems to be an inflammatory process, and cytokines are one of the signals that we have that there's inflammation going on that may contribute to depression. There's also structural changes in the brain that appear to be associated with major depression. So there's decreased volumes in certain brain regions, especially the prefrontal cortex, in the hippocampus, the amygdala, and the basal ganglia. And then there's also functional changes in the brain that appear to be associated with major depression. So for example, there appears to be decreased blood flow in the prefrontal cortex. And then finally, there are genetic factors associated with major depression. So most research has been done on serotonin transporter genes and polymorphisms in that gene. Now, how do these apply to people with multiple sclerosis? So to what extent do the studies really apply in terms of the neuropathology? Well, what do we know so far? We know that there are neuroendocrine abnormalities in people who have both multiple sclerosis and major depression. It's estimated that about 50% of people with MS and major depression have a dysregulation in the hypothalamic pituitary axis. We also know that certainly inflammation and the immune dysfunction is a hallmark of multiple sclerosis. And so we think that the inflammation that is inherent to multiple sclerosis also may contribute to major depression. And finally, there seems to be evidence of structural changes in people with multiple sclerosis in the central nervous system, brain areas, that seem to be consistent with what we know about structural changes in major depressions. So for example, there's been a number of different studies, but one study showed that there are lesions in the superior frontal and parietal regions that are associated with depression and multiple sclerosis. Now, we're very concerned about depression in people with multiple sclerosis because it appears to add significantly to the impact, the disability associated with this disease. And so I just want to outline a few of the ways that depression appears to add to the disability in people with multiple sclerosis. So if you look at people who have MS and are depressed versus people who have MS and aren't depressed, it appears that the people who have MS and depression indicate that they have lower scores on attention and concentration measures. So studies actually testing these people. It's not just their subjective report, but actually how they test appears to be there's more impairment in these areas. If you ask about quality of life, it appears that people with depression and MS have lower quality of life than their comparison group. People with MS and depression have increased time loss from work. They rate their health more poorly. There's also concern from studies several years ago that depression in people with MS is associated with poorer adherence to disease-modifying therapies. And in fact, there's some evidence that depression is possibly associated with disease progression in people with MS. And finally, of great concern, there's an increased risk of suicide in people with multiple sclerosis, and we think that depression contributes to that significantly. With regard to suicide in people with MS, we know that the rates of completed suicide in that population is about double what we'd expect from the general population. And the lifetime prevalence of thoughts of wanting to kill oneself is about 28.6% in people with MS, quite high. So what contributes to this higher suicide rate? Well, the most predictive and strongest predictive factor is the presence of a major depressive disorder in that person. That's the most powerful predictor. Now, other factors such as younger age and being male and social isolation and misusing alcohol also seem to contribute to that increased risk of suicidal behavior and suicidal ideation. But depression appears to be the most predictive factor. So unfortunately, because although depression is widely recognized as being common in people with MS, although depression appears to add to the disability significantly in people with MS, unfortunately we have not really done a very good job of treating depression in people with multiple sclerosis. So what contributes to that? Well, first of all, there's evidence that there's under-recognition of depression in people with multiple sclerosis. In one survey that asked people to what extent they had certain comorbidities, 46% of that sample indicated they had depression along with their multiple sclerosis. When that group was surveyed for depression symptoms, 16% of those people that didn't indicate depression was a problem for them actually scored in the significantly depressed range on the test, indicating that about 16% of the sample was undiagnosed with major depression. Also, low income is associated with not only with higher rates of depression, but also greater odds of being undiagnosed with that depression. In addition to under-recognition, there appears to be significant under-treatment of depression in people with MS and depression. So one survey indicates that between 59 to 67% of those with depression or major depression and MS were not being treated at all. Then looking at those who were treated, 41% were taking antidepressants but were still depressed. The depression hadn't resolved. Predictors of being undertreated vary a lot, but some of the predictors include lower education, males appear to be more undertreated, not having insurance, and not being on any kind of disease-modifying therapy. Unfortunately, the evidence suggests that depression that's not treated doesn't resolve on its own, doesn't resolve spontaneously, but does continue for an extended period of time. Now, there are many barriers to identification of people with depression. One of the barriers is that people are often not really too excited about admitting that they have depressive symptoms. A lot of times people feel like it's a failure, they feel personally responsible, and so they may be reluctant to admit the symptoms. So therefore, it's really incumbent on clinicians to ask specifically about the presence of depressive symptoms in our patients. Another factor that may be a barrier to identification is that clinicians are often too busy to do screening. Well, fortunately for that, is that there's been a nice development in the terms of brief screen. So a 2-item screening measure has been developed that correctly identifies 99% of people with major depression in a population of clinic patients who have MS. The clinician simply has to ask 2 questions. One is, during the last 2 weeks, have you been bothered by little interest or pleasure in doing things? The second question is, have you been bothered by feeling down, depressed, or hopeless? If the patient indicates affirmatively to either of those questions, that indicates a positive screen and the person is very likely to have a major depression. Another thing that's been a barrier to identification of depression in people with MS is the fact that many of the symptoms of depression overlap with symptoms of multiple sclerosis. So it's difficult to tell to what to attribute the symptoms, to MS or to depression. And so, for example, on this slide, the yellow symptoms indicate symptoms that we consider transdiagnostic. They could go one way or the other. So symptoms like insomnia or hypersomnia, psychomotor changes, fatigue, or poor concentration could be attributable to either depression or multiple sclerosis. And what happens is that lots of times clinicians fail to notice those symptoms or attribute them to depression that could result in underdiagnosis of depression in this population because the clinicians are worried about overdiagnosis. They're worried that, oh, I shouldn't count that fatigue symptom because that's due to their MS, that's not due to depression. Well, there's some interesting data on that topic. Crawford and Webster looked at fatigue specifically to look at the extent to which fatigue contributes proportionally or disproportionately to a total score on a depression measure. As you can see on this slide, there's a red horizontal line at 4.8%, and that indicates the amount of depressive symptomatology that fatigue should, all things being equal, should account for in this overall depression score. And as you can see then on the far left, with people with minimal symptoms of depression, fatigue does appear to contribute more proportionally to the depressive symptoms than it should. It's well above that 4.8%. But you can see as you move to the right and get into people who have moderate or severe depression, you can see that the fatigue symptoms really don't contribute much more than they should to the overall depression score. So what I take away from this really is that we shouldn't be ignoring symptoms like fatigue in people with multiple sclerosis. We shouldn't be attributing them only to the multiple sclerosis, but we should also consider the possibility that they may also be part of a depressive syndrome and count those symptoms when we look at the overall symptom picture. Other barriers to treatment are that, understandably, clinicians are prioritizing medical treatments over psychosocial treatments. I mean, they're trying to make sure that they give the people with MS the best possible medical care and take care of their physical symptoms. But nonetheless, we should remember that depression treatment also has significant benefits in terms of physical symptoms for people with MS. So, for example, depression treatment appears to reduce fatigue and the impact of fatigue on one's life. Antidepressants appear to have favorable immunologic effects in people with MS. Effective depression treatment improves adherence to disease-modifying therapies, so it actually makes the impact of those disease-modifying therapies, it might bolster those effects more to some extent because of the benefit of having the depression treated. And then finally, treating depression by itself appears to reduce disability in people with MS and improve their quality of life. All right, so now we're back to kind of the big picture here in terms of what are all the factors that contribute to depression in people with MS. And so we're looking at all these factors, and I'm calling them now modifiable risk factors because we can look at each one and look at to what extent we could address these factors. What could we do to impact them to try to impact depression? So the next slide really looks at possible interventions then at these same things. So for the neurobiological effects of major depression or the neurobiological risk factors, we can use antidepressant medications. Selective serotonin reuptake inhibitors are one of the main classes of antidepressants used, and I'll go over those in a minute. We can also use what's called behavior activation, which is an evidence-based form of psychotherapy that's used to help people become more active in their lives, engage in pleasant activities and meaningful activities. I won't be talking about behavior activation today because it's really an area that has almost no research at all in people with MS in terms of treating depression, but it's an area that merits some more investigation. I also won't be talking about vocational rehabilitation. Although we have wonderful vocational rehabilitation programs and counselors in our department, really little research has looked at vocational rehabilitation as one of the ways to address depression in people with multiple sclerosis. But it's something that we should look at because we know, again, that psychosocial adversity, things like losing one's job or becoming impoverished, does seem to make a difference. So helping people return to school or work or other meaningful activities may have a big role in treating depression in this population. I will talk about physical activity as one of the ways we can try to impact depression in this population. And I also will talk about cognitive behavior therapy as one form of psychotherapy that tries to treat depression in this population. Right, so next, or first of all, I'll just talk about antidepressant medications. And what I want to emphasize with this slide really is that a big myth about antidepressants that cause people to be reluctant to take them sometimes is that they think that taking a medication for depression is like putting something, unnatural in their bodies. It's going to make me high or so forth. And what this slide tries to illustrate really is something very, very different. And that is the fact that antidepressant medications, the major class selective serotonin reuptake inhibitors, actually work with our own neurotransmitter systems to make them more effective. The SSRIs actually block the reuptake of some chemicals that are actually useful. So it helps more of the chemicals stay around in the nerve junction where it can be effective. So it really, antidepressants, what I want to emphasize is that they really help our own body, our own natural neurotransmitter systems work more effectively. They don't make us high, and so it's not. It's a natural way of really dealing with the biological side of our major depression. There have been 3 randomized controlled trials of antidepressant medications for major depression in people with multiple sclerosis. At the bottom, we have the first one by Schiffer and Weinman back in 1990. And what they did is they looked at psychotherapy plus desipramine, which is a older antidepressant medication, versus psychotherapy alone. And what they found is that if you look on the right-hand column, HRSD stands for the Hamilton Rating Scale for Depression, which is kind of the gold standard rating scale for depression severity. And here I have the post-test scores, the means and standard deviations. So you can see that next to the psychotherapy plus desipramine, people ended up in that group with a depression score of 12.7, and the people who had psychotherapy alone had a score of 20.1. So a significantly higher rate of depression or severity of depression in people who had psychotherapy alone, a significantly lower depression severity in people who had desipramine plus psychotherapy. So they determined that desipramine was effective for treating depression as a result of that study. In 2001, David Moore did a study comparing cognitive behavior therapy to sertraline, which is Zoloft, an SSRI antidepressant, and then compare that to a support group intervention. And what you can see in the middle column are some percents there, and the percents refer to the proportion of the people who ended up after that trial having had at least a 50% drop in their depression severity from the beginning of the trial to the end of the trial. So you can see here, let's look at the sertraline versus the support group, that 24% of the people who received sertraline had a 50% drop, at least a 50% drop in their depression severity, and only 14% in the support therapy group. So that turned out to be a significant difference between those two groups. And over to the right, you can see that the depression severity score is 13.9 depression severity at the end of the trial associated with sertraline, and 15.7 in the support group. And again, statistically significant difference between those two groups. Cognitive behavior therapy, which I'll get to later, actually had a little bit better effect, although it wasn't statistically significant from the sertraline. It was significantly better than the support group. Then finally, a study done here at the University of Washington by Dr. Don Eady and colleagues in 2008 examined the efficacy of paroxetine or Paxil in people with both MS and major depression. And when she compared that to a placebo drug. So in her study, the people with paroxetine, 57% of that sample, of that group that received that treatment, experienced at least a 50% drop in their overall depression severity, compared to 40% experienced a drop commensurate with that in the placebo group. So it's a 17% difference. It's not statistically significant, but it was, at least it's in the right direction. And if you look at people who completed the trial, who actually took the medications throughout, they had a little bit higher response rate in the 70% range. So this is, since the studies, there's some controversy over whether or not antidepressants are effective in this group. So Dr. Scott Patton has done a pooled results of all these 3 randomized controlled trials, and it was recently published in the International Journal of MS Care. And he wanted to look at, well, what happens if you look at all these studies together? And what he emphasizes here is that, as you can see on this slide, that all of the studies, the effects there indicated by the blue squares, are all favoring the antidepressant effect being positive. They're not in the middle, which indicates that there's equivocal effects. They're not on the left side, which indicates that the placebo did better. They're not way over, but they're all are on the right side of that line, indicating that in general, the results are not super strong, but they all indicate that antidepressants are probably helpful. So the take-home points from this survey of the antidepressant literature really is that antidepressants probably have modest efficacy for treating major depression in people with multiple sclerosis. Antidepressants may be more effective for people with moderate to severe depression, and that's consistent with a recent paper that looked at the efficacy of antidepressants overall in people with major depression, regardless of their medical conditions, that the antidepressants seem to work better for people who have at least moderately severe or more severe symptoms at the beginning. Another thing to note is that antidepressants may not get rid of all the symptoms. The person may not achieve what we call remission, which is complete remediation of all their depression symptoms. Remember that some of the symptoms that overlap with major depression are actually attributable to multiple sclerosis. So some of those symptoms may remain. Fatigue to a certain degree, maybe concentration problems aren't going to go away totally due to antidepressants. And then finally, it may turn out to be more effective to take a combined approach using psychotherapy and antidepressant medications together. That might produce a greater efficacy in this population. Another thing to mention about using antidepressants in people with MS and major depression is that lots of people discontinue these medications early. They may experience some side effects. They may not feel like they're getting better. So lots of people who have major depression and start antidepressants discontinue too early. And that seems to be the case in people with MS as well. They discontinue the medications within 1 month, 20 to 30%. So what needs to happen really is that much more close follow-up needs to happen in this population. So we recommend that people follow up every 2 weeks with their doctor if they're starting antidepressants, that they come back and see if the antidepressants are helping, make sure that their dose gets increased appropriately according to what their physician recommends, that also that they work with their physician to change antidepressant medications if that's indicated, if the first one isn't working, or there are ways to also boost the efficacy of antidepressants or add other strategies, other medications or psychotherapy or exercise to bolster the effect of the medication. So next I want to talk about cognitive behavior therapy. I want to start with a bit of a caveat because since I don't have MS, I can't imagine what it's like to be diagnosed with this condition. It must be overwhelming, it must be frightening, it must be very troubling. And that said, there is also evidence that people can have kind of catastrophic thinking about their MS. They can worry about the effect of MS and even magnify it to make it worse than it actually is. And that magnification of their worries, their fears, their doubts, and so forth can add to increased emotional distress. So the premise of cognitive behavior therapy is that we all kind of create our own reality. We think about things in certain ways. We interpret what's happening to them. We have these reactions, and that our thinking about things is really what drives our emotion. If I fear something so greatly, or if I feel hopeless if I think that something is hopeless, I'm going to feel hopeless. If I think something is fearful, I'm going to feel fearful. So the idea here is with cognitive behavior therapy to really examine our beliefs about something. Yes, having a diagnosis of MS may be devastating for somebody, may be frightening and so forth, but can we think about it even more accurately? Can we think about what the chances are that I'm going to progress? Can we think about the chances that I'm going to be able to function well tomorrow and so forth and be able to achieve the goals in my life? The idea there is to identify the symptoms that have to do with how we think about our disease, how we think about our future and so forth. Identify these symptoms, identify which ones may be exaggerated, maybe where we're catastrophizing about what's happened to us. And to begin looking at them more carefully and to try to come up with a realistic appraisal of what we think about what will happen or what our fears are. And to begin gently to maybe challenge some of those distortions that we might have about what this means in our lives. Since there's a cognitive and behavioral therapy, there's a behavioral aspect, and the behavioral aspect really involves kind of experimenting and finding out, trying to reintegrate with things that we enjoy, things that we find meaningful, trying to do things that are pleasant in our lives and build those things back in. I emphasize cognitive behavior therapy because it's been effective in people with MS for treating depression. Back in the mid-'80s, 1984, Larcom and Wilson did the first cognitive behavior therapy study for people with MS and depression. They found that it was effective in comparison to a group that just were on a wait list. And then we owe a great debt to David Moore, who's done a number of studies of depression and cognitive behavior therapy. One of his studies was done in 2000. He did a telephone-administered cognitive behavior therapy that he called Coping with MS. And that intervention, which only lasted 6 or 8 weeks, resulted in a significantly decreased symptoms of depression in that group that received the treatment compared to people who received usual care. He's done subsequent studies where he randomized people to 3 groups, as I mentioned before. One received sertraline or Zoloft, one received the cognitive behavior therapy, and one received the support group. And really what they found was that either the sertraline or the cognitive behavior therapy was more effective than the support group. And as you may recall, 50% of the people who received the cognitive behavior therapy had at least a 50% drop in their symptom severity over the course of that trial. Then he's done a study more recently in 2005 where he had even tighter controls, a more challenging study where he compared telephone-administered cognitive behavior therapy to telephone-administered emotion-focused therapy. And really what he's trying to get at there is it the cognitive therapy or is it just calling somebody on the phone and allowing them to talk about their feelings? You know, trying to take out those what we call the non-specific effects of telephone contact or having a warm, nice person talking with you on the phone. Is it the cognitive therapy or is it just the nice person? And it turns out that actually the telephone cognitive behavior therapy was significantly more effective than the emotion-focused therapy, the warm person on the phone. So there's pretty good evidence that it's really the specific type of therapy that plays a role in helping reduce the symptoms of major depression in people with MS. I want to mention that it's not just reducing the symptoms in the short term that the cognitive behavior therapy does. It really looks like the effects of CBT extend for a long period of time. So Dr. Moore looked at some follow-up data on the people that were in his study and found that the effects of the cognitive behavior therapy on mood lasted 12 months. Fully a year later, people were still benefiting from that treatment, had not become depressed again. And not only that, but cognitive behavior therapy seems to have more widespread positive effects in people with MS. So according to using the Guy's neurological disability scale, people who'd received cognitive behavior therapy had greater improvements in their neurological disability. And also people had reduced fatigue impact compared to the control group. So the take-home points with regard to therapy really is that psychotherapy, but not just talking or any kind of psychotherapy, probably something more akin to cognitive behavior therapy is effective for depression in this population. So it really makes a difference about the therapist's training and experience, whether they have specific training or experience in doing the CBT. That may be the critical factor. We have to admit that access to trained clinicians in different areas may be difficult. So that may be an issue. And unfortunately, right now anyway, telephone therapy is not paid for by insurance companies, but we're hopeful in coming years that we'll be able to have insurance companies cover telephone-based therapy, so that may help people in outlying areas. All right, the next thing I want to move on to really is physical activity. So why use exercise to treat depression? Well, because there's a big body of literature looking at the relationship of exercise to depression. Let's start with people who don't have multiple sclerosis. We know that in cross-sectional studies, people who are more active or exercise more report less depressive symptoms. And then if you look at longitudinal studies where people who are less active at baseline, they're more likely to be depressed at the follow-up. And then people in longitudinal studies who are inactive at baseline but then become active later on, those people have less risk of becoming depressed because they became active. So that's kind of the beginning of this all. We also know that there's been some research studies, actual intervention studies, to show that exercise appears to improve depression in people who don't have multiple sclerosis. So exercise is an effective form of treatment for depression among healthy human subjects, people with psychiatric patients, and people who are older adults. Exercise is as effective as antidepressant medications in older adults. And it appears that both aerobic exercise as well as non-aerobic exercise have antidepressant effects. This is a slide from Blumenthal et al. In the Archives of Internal Medicine in 1999 showing the effects of sertraline, the antidepressant Zoloft that was used in Dr. Moore's study as well, the effects of aerobic exercise, and the effects of the combination of the two in older adults. And so you can see with the gray bar, that's the baseline depression, and then you see nice decreases in depression severity at the end of the trial after 16 weeks, as represented by the yellow bar on that using that Hamilton Depression Rating Scale measure. So you can see that really all three groups had nice decreases in depression severity across the board, and none was really greater than the other. What was different was that Blumenthal's group looked at to what extent people were depressed 10 months later after the trial was over. And the red arrows point to what we call the relapse rate. That's the proportion of people in each group who became depressed at that 10-month point. As you can see in the exercise group, the relapse rate was significantly lower than in the medication group or in the combined group. And we think that the lower relapse rates associated with exercise was probably because people kept exercising and enjoyed it and it made it part of their lives, so they were able to continue that. Another hopeful thing about exercise and physical activity is that more is better. This is a study by Dunn et al. Looking at the effect of exercise in depression in a normal population that doesn't have any other physical disorder. And you can see at the top there, it shows the baseline level of depression represented there at about 16 on the Hamilton Depression Rating Scale. And you can see that in what's called the control condition, which is really people who did flexibility exercises 3 days a week, you can see that there's a significant drop in depression severity, even in that group that just did stretching. And then if you look to the right, you have the low intensity exercise group, and they also dropped their depression severity scores significantly from baseline. And then you look at what's called the PhD level, the public health dose of exercise, which is more moderately intense exercise for 150 minutes per week. And you can see that that group had an even greater effect on their depression symptoms compared to both the baseline and also compared to the other two groups. So it looks like a little exercise and even stretching might help with mood. More intense exercise helps as much, and then even more intense exercise, that is moderate activity for at least 150 minutes a week, appears to have even a more significant effect on depression severity over time. The nice thing about looking at exercise in people with MS is that there's pretty good evidence that exercise has widespread positive benefits for people in MS generally. We have evidence that endurance training results in improved exercise capacity, physical and psychosocial functioning in ambulatory people with MS. There's evidence that multidisciplinary outpatient rehabilitation results in less disability, greater health-related quality of life, lower depression and fatigue among people with progressive multiple sclerosis. And then there's a nice natural history study done by Alexa Stufbergen looking at how the relationship between exercise or physical activity and functional decline over time. And what she found is that if you have low activity levels at baseline, that predicts greater functional decline 5 years later. If you have high levels of activity at baseline, that predicts less functional decline over 5 years. So how do we think exercise might work as a treatment for depression in general? Well, the possible mechanisms are listed here. So we know that exercise from other laboratory studies, a lot of animal studies, actually increases serotonin production, one of the chemicals that we think is critical to triggering depression. It also reduces the reactivity of the hypothalamic pituitary axis in response to stress. Exercise actually increases the size of some of the brain structures that are important to depression. So we know that the hippocampus actually has increased rates of birth of new cells when animals exercise. Exercise increases pleasant events. It distracts us from our negative emotions. It increases a sense of self-efficacy. Many people who've tried to exercise and got into the gym and worked out, and we knew how good it feels to get out there and be more active. And that increases our general sense of being able to handle the challenges that we face in our lives. And depending on how one exercises, it also may increase our social support. Another nice thing is that people with MS want to exercise. This is a survey we did several years ago looking at what kind of help did people with MS want. We looked at a clinic sample and a community sample, and we found that 77% of people in clinic and 86% of people in the community said that they were interested in having help with exercise. So we ended up doing a study looking at the effect of increasing people's physical activity or exercise in people with MS, people who had major depression at the time the study started. These are also people with MS who had more moderate disability. They were able to ambulate at least 300 feet, so they could walk if they needed to as part of the study. So you can see from this participant flow chart that we screened 555 people, and we ended up, after people declined or were excluded, we ended up randomizing about 101 people, half to a control condition, which is a weightless control, and then half to a treatment that was designed to improve their level of physical activity. So an overview of the intervention is as follows. We had an initial face-to-face session with our study staff person that lasted about 60 to 90 minutes. And in that session, the therapist would provide the person with MS with feedback about a baseline assessment, basically things that had to do with how much they exercised, how active they've been in the past, what kinds of activities they enjoyed, and so forth. And then they would use a counseling technique that's referred to as motivational interviewing. It's basically a way of talking with people that is client-centered and respects their own thoughts and feelings about how best to proceed. And they use that approach to develop an individualized exercise plan with that person. And then that group received 7 telephone counseling sessions, each lasting between 15 and 30 minutes at weeks 1, 2, 3, 4, 6, 8, and 10 after that baseline assessment. And then finally they came in for a 12-week follow-up in-person counseling session to see how the person had done over time. In the initial in-person session, and really in the subsequent sessions too, what the therapist tries to do with the person is really try to look at their past and current levels of physical activity, the barriers to achieving their goals of physical activity, really ask them about their core values and what's important about physical activity to the person. How could it improve their health, both psychological health as well as their physical health. So really look at the benefits of exercise. They came up with an exercise plan that the person thought would be doable and enjoyable, and they talked about ways to try to overcome the barriers to physical activity in their daily life. So the first question is, were we able to get people to become more active? And fortunately, we were able to help people become more active. As you can see in the blue bar, that represents the baseline level of activity or metabolic equivalence, and the yellow bar represents the 12-week level of activity. And you can see that there's a nice increase in activity among the exercise group, and the weightless control group had a non-significant increase in activity. And at the end of the trial, the people who had received exercise were exercising more, or were more active than the people in the weightless control, which was a relief. Next really is our key question though, which is what was the effect of the exercise on depression severity? On the left-hand side, the group of bars start with the baseline activity, or baseline depression severity being over 17 in the exercise group. And you can see a nice drop from the blue bar to the green bar over the first 12 weeks of the trial, showing a nice decrease in depression severity in that group. And looking over at the right to the weightless control group, you see very little difference between the blue and the green bar, indicating no significant difference or drop in depression severity among that group. If you look again to the exercise group, you see a yellow bar, which indicates that the group that received exercise not only became less depressed by the end of the trial, but at 24 weeks, 12 weeks later, their level of depression was still the same. So the maintenance of the effect of the exercise on depression severity was good over time. So we looked at some other secondary outcomes. We wanted to see if maybe exercise would improve people's level of fatigue, and that's what we found here. You can see in the exercise group that there was a nice drop from baseline to 12 weeks in the person's level of fatigue impact, whereas in the weightless control group there was no change in fatigue impact on their lives. One of the things we were really concerned about was perhaps exercise would have negative side effects for people with multiple sclerosis. We were worried about injury, we were worried about people becoming overheated, people having other symptoms that might cause them some distress. There might be a downside to becoming more active in people with MS. So we were worried about that. So we administered, I think, a 22-item a 22-item side effect measure to people with MS that covered many of the common side effects that are associated with exercise that could occur. And what we found really was that not only did exercise not make side effects worse, it appeared to make the side effects better. There's actually lower rates of side effects in the people who exercise versus the control group. And there was a nice drop from pre-treatment to the 12-week point in terms of side effect severity in the people who received exercise. So we didn't really find a downside to becoming more active in people with multiple sclerosis. So in terms of summarizing, what I want to emphasize really is that, again, major depression is a biopsychosocial disorder. It has various components, various risk factors that contribute to it. We talked about today about how our thinking might contribute to it. We talked about how our activity might contribute to it, how our biochemistry might contribute to it. We didn't talk as much about how our environment, how social adversity might contribute to it, but that's also a factor. We also didn't talk about just how a sheer activation maybe contributes to that, but also those factors can all contribute to it. So the key thing here is that we need to think about depression as something that people should not be blamed for or ashamed of, but something that has multiple determinants, multiple things converging, and especially in people with multiple sclerosis, it appears to be associated with higher rates of depression in that group, and that it's probably a secondary condition associated with multiple sclerosis that really they have limited control over. We think we can intervene in that, but in terms of it coming on, it may come on more in people with MS because of their disease processes. Unfortunately, despite the prevalence and the impact of depression in people with multiple sclerosis, so far our ability to treat that problem appears to be inadequate. We have treatments that are effective, but we don't recognize the need for treatment soon enough or frequently enough, and that lack of recognition, lack of treatment, probably contributes to the high rates of depression in this population. It looks from the literature that we have so far that antidepressants are actually effective in people with multiple sclerosis and major depression, especially if you look at people who have more moderate to severe symptoms, and especially if they really follow up with their physician, especially if they stay on the medication long enough, especially if they have their dose increased appropriately as indicated by their physician. There's a pretty good chance they can achieve a significant reduction in their symptoms following that path. Cognitive behavior therapy in particular may also be an effective treatment for depression in this population. Unfortunately, cognitive behavior therapy is underutilized in this population, so much needs to be done to try to help us make it more available to people, make it more accessible to people with MS and depression. Physical activity appears to have widespread benefits, positive benefits for people with MS, including it appears to help with mood in people with major depression. So there's another benefit we can add to physical activity in this population. And then finally, I would guess that combining therapies would potentially even be more helpful. One of the things that we learned in our study on exercise is that exercise seemed to have a positive effect on depression because it helped people feel happier. It didn't help them solve their problems as the pathway to improving depression. It seemed to help them feel happier. So if you combine an intervention like a depression that helps people feel happier with one that maybe helps solve their problems, maybe we could even bolster the effect of our interventions on depression in this population. All right, the last thing I want to mention is really where to get help. If you have concerns about any of the symptoms of depression, we encourage you strongly to talk with your doctor about those symptoms. Talk with your doctor about counseling and medications. Ask if you have significant symptoms, ask about treatment and close follow-up until your depression remits. It's also helpful to look at the National MS Society website that we have here for you. It has a ton of great information, including information about depression in people with multiple sclerosis. Thank you very much.
Chuck, that was superb.
Thank you.
I really learned a lot, and I hope you at home learned a lot about depression. And I was sitting over there taking notes. So I have a few questions and comments for the talk, okay? Depression and MS is real, right?
Definitely.
And people with MS who have depression should realize it's frequently part of the disease and not to feel even more depressed over having it.
Absolutely. It's part of the disease. It seems to be more prevalent. So we think that they have a big risk factor just by having MS.
Yes. You presented some data that indicated that independently medications, antidepressant medications, different types, but all antidepressant medications, something you called CBT or cognitive behavioral therapy, and exercise independently help. And you suggested maybe putting them all together might be even better, right?
I think so. I think there's a good chance. I'm not sure, but
But there have been no studies of all three. You've done studies, there are studies of 2 of the 3, but not all 3, is that correct?
That's correct, yeah. So.
Okay. Can you describe what CBT is? What does it involve? What does somebody have to go through to have it?
Also, cognitive behavior therapy usually involves meeting with a therapist for maybe 8 up to 16 sessions and really talking about several different things. Really, start thinking about trying to notice the way we think about, for example, our disease of MS, how we're thinking about the other stressors in our lives, and beginning to kind of notice the relationship between thoughts and feelings. And then once you start noticing the relationship between thoughts and feelings, with the guidance of the therapist, really beginning to kind of look at to what extent our thoughts are accurate, or could they be more accurate? Are they overly pessimistic? Are they overly optimistic? And beginning kind of noticing the relationship there, and maybe deciding that maybe I could be thinking differently about some of these things. And if I thought differently, if I, for example, more optimistic or less thought in less fearful terms, or decrease some of the catastrophic thinking I might be having, that might have an effect on mood. And so then a person begins experimenting, kind of switching out and thinking in different ways and seeing if that changes their mood, and oftentimes finding that it does. And then in addition to that, people begin experimenting with their routines in their lives, their activities, what they spend their time doing, and seeing if those things also maybe influence their mood, and finding things that they find bring them more pleasure, more meaning, things that boost their mood. And so it's really working with a therapist to, do those things together and basically build those things into your life as more of a habit, and then seeing what effect that has on your mood and the rest of your life.
You mentioned Dr. Edie's study. That was a big survey done in the Northwest about the prevalence of depression, and I was part of that study. And as I recall looking at the data, there were possibly 2 peaks. There was a peak sort of early in the diagnosis, early after the diagnosis, and then later in the disease. And I'm a clinician who takes care of a lot of MS patients, and I think I see that in practice. That right after somebody is diagnosed with MS, they appear very depressed, and I would assume that's really situational. That it's a depressing thing to have been told that you have MS. And then as we follow patients later in the disease, as they have more extensive lesions in the brain, we see more depression there too, and that probably is more organic, would you say? But don't you think at both points some intervention would be appropriate?
Absolutely. I think that biopsychosocial model tells that there's multiple factors impinging on the person and creating risks for depression, and that may be stronger at one point than the other in terms of the disease course. But whether it's early after they've been diagnosed or later, I think intervention is important.
I want to comment also a little more about Dr. Edie's study. I think it was really the only one, and certainly the largest study ever, to have a placebo arm. And we do know that in MS and other conditions, that just taking a medication has what we call the placebo effect. And it's estimated in MS it might be up to 30%, that just by knowing you're on a treatment that you feel better, and you just feel better, and that's the placebo effect. And one of the criticisms of some of the other studies was that they didn't have really a placebo arm. So Dr. Edie's study did have the placebo arm, and I want to tell you about a patient I had. And as a treating physician, I didn't know, I knew if my patients were in the study, but I didn't know if they were getting the placebo or the medication. And I had this gentleman in his mid-50s, and he'd had MS for maybe 20 years, and he was struggling to keep a small business going. And he was pretty clearly depressed, and I encouraged him to sign up for the study. So next time I saw him, about 6 weeks, 8 weeks later, he just was smiling, and he said his business is going better, he's doing well, and he says, I'm really impressed with that effect of that medication. And then it turned out he was on placebo. And he came back and he was so depressed. He said, Dr. Kraft, it must be in my head. So isn't that really where depression is? But it is important to recognize that if you think you're doing something good, it will make you feel better. There's nothing wrong with that.
Nothing wrong with that at all.
There are no side effects in placebo. Well, thank you, Chuck, very much. It
Thank
was
you very
just
much.
superb. Well, that was our session on depression and MS. And it's a very real thing. People with MS have depression. And we mentioned what we think would be best to do for it. We're still learning about this and learning new ways to treat this disease. One of the things we're trying to do in this 9-part series, MS from A to Z, is to give you information about some of the things that happen to people with MS that need to be managed, give you some information about how they can be managed. And I want to encourage you all, when you see your healthcare provider, to remember that MS causes a lot of problems. And yes, taking the disease-modifying treatments is very appropriate, but there's a lot more of the disease than that. So talk to your healthcare provider. Talk about your symptoms, spasticity, weakness, depression, memory problems, any symptoms you have, because there can be some independent treatments of symptoms. And with the treatment of the disease and the treatment of the symptoms, you will be a lot better off. Thank you very much for watching this series, and I hope you tune in to subsequent programs in this series. Thank you very much.